Okay. Now, how is that? Does that look right? Okay, great. Well, thank you so much for the invitation to be here and to come again in March. I'm really excited about that one as well. I wish I could actually come in person because I love visiting Georgia. That's where I'm from and that's where my family is. Today, I want to spend some time talking to you about some of our recent research that we've done over the last year or so using mathematical models to understand COVID-19 epidemic dynamics and control. And to back out a little bit, I think one way of thinking about the problem here is when thinking about evolution in action. When Peter and Rosemary Grant were interested in trying to study evolution in action in the field, they went to this place, Daphne Major, in the Galapagos Islands. That was this extremely extreme environment. It's basically a hump of volcanic rock with a little bit of vegetation on it in the middle of the Pacific Ocean. And within this island setting, basically everything is constrained and controlled. You have this population of birds that they were able to track, and they were able to measure every single bird and count every single bird and track its fate through time. And over a period of over 30 years, they were able to basically watch as evolution in action played out. They were able to watch speciation, assortative mating, hybridization, competitive displacement, some of these big picture fundamental ideas of evolution in action over ecological timescales actually played out before their eyes because they were able to not only sort of infer or estimate processes of evolution, but actually directly observe them in this really constrained kind of controlled setting where all the processes that were relevant to evolution could be directly observed and measured. So if we're similarly interested in infectious disease dynamics, how do we study epidemics in action? How do we find that type of really controlled setting? We could turn to a place like a cruise ship where we have, a passenger manifest and we have room charts. We know exactly who was there and how long and where they were staying. Or we could turn to an island nation like Australia or New Zealand, where they've effectively been able to cut themselves off from the rest of the world and impose a really consistent and sustained set of policy that has allowed them to control epidemic dynamics and really apply it very consistently across the whole country without having huge numbers of importations. So these are the types of controlled settings where you might be able to actually study epidemics in action in a similar sort of way. But what do we do if we're interested in a place like the United States, where we have this huge, messy, heterogeneous, poorly controlled epidemic, and we're trying to study it in real time as it unfolds? We're trying to not only study it and learn from it, but also react to it and try to respond in a way that's helpful and helps us to control the epidemic. And how do we actually gain knowledge that can be useful for the future and not just over the next few weeks or months as we're confronting COVID-19? So I would argue, and I don't think I'm going to face a lot of resistance with this crew, I would argue that one of the key tools we have for studying epidemics in action under these really messy and poorly controlled situations is using epidemiological models, because they allow us to make the unobserved measurable, and they allow us to do hypothetical experiments that can tell us what could have been and what could be going forward, depending on how we change our behavior. So my part of this story really starts on March 11th or so, almost a year ago. We were not sitting in our beautiful new biology building that you see here on Stanford campus. In fact, we had started to work from home. And in fact, we were having the now familiar Zoom lab meeting for one of the first times. And this lab meeting in particular, I'll go back to this nicer picture. This lab meeting in particular, we had kind of started to recognize that COVID-19 was going to be not just something going on in the background, but a much bigger influence on all of our lives than we had previously realized. We don't traditionally work on respiratory viruses, and there are many people who do amazing work trying to model the spread of respiratory viruses, and that's not the work that we were doing previously. So we hadn't initially jumped into trying to work on COVID-19. But as we quickly realized that, this was going to be something that was going to affect all of our lives, and it was essentially going to be the 1918 flu pandemic of our generation, suddenly it felt silly to sit on the sidelines and not be informed and not be thinking about how we could contribute and how we could help. So during this infamous Zoom lab meeting, we divided up what already at the time on March 11th felt like an overwhelming literature, especially in the preprint literature. And we each read a few papers on COVID-19 and kind of tried to get up to speed on what was going on, what was known, what was being discussed, what were the big questions. And we saw a lot of discussion at this point about flattening the curve. And, really the messaging in the public was, we need to be flattening the curve. We need to, be trying to suppress the epidemic for a little while to allow our medical systems to catch up and prevent them from getting overwhelmed. But we didn't see a lot of discussion on what to do after we flatten the curve. So we can do social distancing and flatten the curve, but then what? How long do we have to keep the curve flat, and how do we keep it flat? The other gap that we saw was that in our local area, we weren't seeing very much modeling coming out. And so we started thinking about ways that our group could contribute, both through modeling COVID dynamics in our local area, which I'll tell you a little bit more about in a minute, and also through, communicating with the public. What does it mean to flatten the curve, and how do we keep it flat? So this happened on March 11th. We started kind of thinking about some modeling and getting some initial modeling going to address those questions. On March 16th, the county, I keep hearing these beeps. Are those people joining the call? I guess maybe you're not hearing them. Okay. So on March 16th, our county, along with 6 other Bay Area counties, announced the country's first in the country stay-at-home order. So this suddenly took it from being this sort of hypothetical distant threat of a potential epidemic to like we're living in a disaster scenario. This is almost like we're having a hurricane or a fire or something like that. We're being ordered to stay at home. Of course, this is a now familiar type of situation, but at the time, this was the first one in the country, the first place in the country where we were ordered to stay at home. And so this really, of course, accelerated our thinking about modeling COVID-19. And by about a week later, we had produced a publicly available website that had this R Shiny app that allows users to use these sliders to investigate different types of interventions and how they affect the epidemic dynamics. And really the goal here was to communicate about flattening the curve. So the work I'm going to talk about today was spearheaded by grad students and postdocs in my lab, primarily the 4 people shown on top here. I'm going to be highlighting their work throughout. It's almost all available publicly on this GitHub repository and Morgan Kane's GitHub. And it was funded by NSF EID, the NIGMS R35 MIRA program, the Natural Capital Project, and the Terman Award. So when we talk about epidemiological models, we typically mean one of 2 different types of models. The first type is the compartmental model, which is the SEIR type of structure, where we take our population of people and we divide them up with respect to the disease. So they're susceptible, exposed, infectious, or recovered. And the key concept of this kind of model is that we're trying to capture the transmission dynamics in the model structure. So we're trying to capture the rates at which people move between susceptible, exposed, infectious, and recovered. And you can get more and more complex versions of this, as I'm showing in this example here. In contrast to this type of compartmental model, a lot of other models are curve fitting models, where you have some sort of an underlying statistical model that tries to capture not the process itself, but just the dynamics of the data. So things like hospitalizations or cases. And these models are really useful for short-term numerical predictions. Like if you're trying to understand hospital bed capacity over the next 2 weeks or the next month, this type of curve fitting model can be really useful for capturing, what's the most likely outcome, and then what's the range of expected outcomes. By contrast, these curve fitting models aren't nearly as good for things like exploring different scenarios and regime changes, because they don't actually capture the underlying process of transmission. And so therefore, they're not as good for saying what would happen if we completely change this process. So that's where the compartmental models can be really useful for capturing that process-based transmission and asking, what would happen if we change transmission? Now, the drawback to these compartmental models is they can be really difficult to parameterize, and they often don't produce as good of numerical predictions over short time scales. So that's kind of the trade-offs of these 2 different types of models. Most of what I'm going to talk about today involves these compartmental models. So the key questions we wanted to address are, first of all, how can early models guide our decision-making? During the period when we know something, but not very much about the epidemic, can these models that we can make based on limited information actually be fairly accurate and useful? And what are the limitations on their accuracy and usefulness? Second, how does averting superspreading affect epidemic control? We'll talk about superspreading a bit more in a minute. Third, how predictable are epidemic dynamics? And fourth, how do early policy decisions and underlying vulnerability affect epidemic dynamics? So just to introduce the model that we built, this is what we had online as of March 22nd. This is our compartmental model. And there are a few key features to note about this model. It's an SEIR style model, but you can see there's a few additional compartments here. And the key features are shown in this yellow color here. So we assume that people transition from being susceptible to exposed with a time varying transmission rate, beta T. And it's important that this transmission rate is time varying because there's an initial level of transmission sort of in the background baseline scenario when there are no interventions in place. And then there's a reduced level of transmission that occurs once some of these interventions have come into play. The other important feature of this model is that it captures transmission from asymptomatic and pre-symptomatic people. So we have this asymptomatic compartment of people who just go from being infectious but asymptomatic straight to the recovered class. The pre-symptomatic people can then become severely or mildly symptomatic. The severely symptomatic people can become hospitalized and either die or recover. So that's the model structure. To parameterize the model, we turned to the MIDAS network, which had a lot of parameter information already available at the time. And the key parameter that we focused on for estimation was this beta T. So the goals of our early model back in March were to estimate a transmission parameter, beta T, from COVID-19 deaths alone. Now, this was important because, as you recall, in March, there was very little testing going on. And so we had a really uncertain picture of how many cases there actually were. And so we estimated that even though COVID-19 deaths are only really a tip of the iceberg of the epidemic, they were probably a more reliable signal of the true size of the epidemic than the number of reported cases. So we wanted to estimate beta of T from the COVID-19 deaths. We wanted to model the impact of these shelter-in-place orders, as well as changes in policy and how that might affect epidemic dynamics. And we wanted to communicate with the public about flattening the curve and keeping it flat. So a couple of key concepts here that you may already be familiar with, but just in case you're not, reproduction numbers are an important epidemiological quantity because they tell us something about whether the epidemic is on average growing or shrinking. So the basic reproduction number, R0, is the average number of secondary infections produced by a single infected individual in a fully susceptible population. Whereas the effective reproduction number is the average number of secondary infections produced by a single infected individual in a population that has some interventions and immunity in place. So these are the two numbers we're going to be focused on for our model estimation. We started our work in Santa Clara County because that's our home. That's where Stanford is located. It's a really interesting county for a lot of reasons. There's almost 2 million people in the county, so it's bigger than a lot of states. It's a really wealthy county. It's the heart of Silicon Valley. Many of us were able to work from home very early in the epidemic. It's also a really diverse county, though, in terms of race and ethnicity, as well as education, as well as occupation. So there's a lot of people, working in the tech sector, working from home, but there's also a lot of people in the restaurant and retail industries. There's a huge amount of inequality in terms of income and housing costs within the county, and you'll see a little bit more of that later. It's really interesting from the perspective that being, the heart of Silicon Valley, it's really well connected to most of the rest of the world, especially including China. And so we had some of the earlier reports of cases in our county. And in fact, retroactively, I think it wasn't reported until late March or early April, but retroactively it was discovered that the first COVID-19 death in America occurred on February 6th in Santa Clara County. So we were a site of early epidemic dynamics. The other interesting thing about our county is that our county public health officers had this really ingenious early sentinel surveillance study that they conducted at the beginning of March. They were worried about the circulation of COVID-19 in our county, but they didn't have enough resources to test a large number of people. So they took people who had reported with influenza-like illness to clinics, and those who tested negative for influenza, a subset of those people were tested for COVID, and 11% of that small subset of people tested positive for COVID. This study came out initially around March 14th. And so what they realized quickly was that, as this quote here says, it's important because it shows that there's transmission of the disease in the community and that the disease was perhaps more widespread than previously understood. So March 14th, the sentinel surveillance study comes out. 2 days later, that Bay Area shelter-in-place order was announced. So it was a really early sentinel surveillance study, and it had an immediate impact on public health, which then was extended statewide 2 days after that. So to go through the timeline of the situation in Santa Clara County a little bit more, here's the number of COVID-19 deaths over the period from March to July. Here's some cell phone-based mobility data. This is the fraction of mobile devices that are sheltering in place. So we can see that there was this kind of quick uptick in March as more and more people and devices started sheltering in place. As of March 5th, many of the Bay Area employers like Apple and Google and Stanford were starting to encourage people to work from home. March 9th, the first reported COVID-19 death was recorded in the county at the time. March 13th, we began developing the model. March 17th, that Bay Area shelter-in-place order took effect. We then spent the next month developing our model. We got the first version online about a week after we started working on it. We had our initial analyses done about a month after the start of the modeling. We had our paper submitted to a journal and a preprint posted on April 30th, so about a month and a half afterwards. And on May 1st, after a good night's sleep, the team went back to working on the model and began updating it already from what we had learned from the first modeling efforts. Around that same time, the Bay Area started relaxing these shelter-in-place orders in the beginning of May. And by the beginning of June, the shelter-in-place orders had relaxed quite a bit. And by the middle of June, our paper was rejected because the model was out of date. So this just shows you how quickly things changed during this period and how rapidly we were trying to learn from these kind of simple models. So the first key output that we found on that initial April 13th estimate was looking at our estimated R0 and R effective for Santa Clara County. So our estimated R0 was around 3 and our estimated R effective was around 0.5. So we were pretty confident in this first estimate that the shelter in place had brought R effective below 1, which meant that the epidemic was going to be declining. But when we looked at the death data, we can see that they're really bouncing around a lot and they're pretty small numbers. So they're going between about 2 and 4 deaths per day. Occasionally we saw as many as 10. So a week later, we reran the model estimates and all of a sudden our R effective estimate had jumped up to 1. So we were no longer confident at all that R effective was below 1. And that was because we had seen this kind of anomalous spike in deaths in the preceding week. So that then gave us pause and we started asking, how robust are these estimates really? And, how certain are we really about what R effective is? So we repeated this estimation procedure. Of course, we were doing this later. You can see the data go through July, but in each case, we're including data up until that date and fitting our R0 and R effective. And then we're continually doing that as we add more and more data into the model. So we can see that initially we were not very confident about what R effective was. We were then a little bit overconfident for a few weeks, and then we became really uncertain and thought that R effective was around 1. And then we start to see this estimate leveling off around 0.7 or so. You can see that the R0 estimate around 3 was pretty consistent throughout the whole period. So given this model fit, what should we do now? This is during a time that we were under shelter in place. So here's our cumulative deaths. The model was actually fit to the incident deaths, but just for visualization, I'm showing the cumulative deaths along with the stochastic model simulations for cumulative deaths, as well as the predicted number of concurrent infections. So we asked, as of the 1st of June, what should the government do? Or what would happen if we underwent different intervention scenarios? And what we found is that it was not only important to flatten the curve, but to keep it flat. If we lifted our interventions, that's shown in red, we would have expected to see a huge resurgence in cases and about 5,000 deaths occurring really quickly within a few months. If we maintained our shelter in place, shown in yellow, we can see that we would have predicted that the epidemic would have gradually declined, but it would have taken a really long time to get down to low numbers of cases. And you can see that most of these stochastic trajectories don't go extinct. And we had sort of this intermediate scenario that we considered, which was relaxing the general social distancing, but then more aggressively testing and isolating symptomatic people. And that was sort of an in-between scenario that allowed us to kind of cap the number of infections at a little bit higher of a level, but they didn't totally get out of control like they did if we had completely lifted the order. So what we did then, we thought this was an important message, that we not only need to flatten the curve, but we need to keep it flat. And we're going to have to maintain some form of interventions over a long period of time to keep this epidemic under control. So we made this our Shiny app and we put it up online, and Stanford News covered our work and sort of got an article out there to the public, which was sort of our goal to communicate to people, we need to flatten the curve and we need to keep it flat. What happened then really surprised me, because a lot of the Bay Area news and TV stations and some other organizations reached out to us pretty quickly and were really interested in this message. What does it mean? Are we going to have to keep a shelter in place for 5 months or for a year? There was a lot of interest in understanding the implications of these results. And there was also a lot of interest from some county public health organizations. I had sort of naively assumed that they had some wealth of modeling knowledge that they were drawing on and that they had some amazing, great mobility data and meta-population models, or, they were somehow very sophisticated in modeling epidemic dynamics in every county. But what we learned was that many counties didn't have access to this type of process-based model that would allow them to examine different scenarios of interventions. And so a lot of these counties and other organizations began using our online code to try to think about how to design interventions going forward, which was not really what we had intended to do with this model. So that really gave us interest in this question: how accurate were these early models? We know that they're really limited in their structure. We know that they're being estimated only from death data, and that there are a lot of assumptions going into these models. So to look at the accuracy, we took our model fits from April 22nd. These are the data that the models actually fit to in black, the death data. And you can see our confidence intervals here around these stochastic simulations are pretty well capturing the death data. These are data that weren't used to fit the model here. These are the case data, but we can see that the model corresponded pretty well with the shape of those case data, with an estimated underreporting of about only about 10% of cases were being reported as estimated from the model. If we then look at out of sample data that weren't used to fit the model, we have this initial 2 weeks after the model fit shown in red, and then the time after that shown in pink. You can see that for the death data, we did a pretty good job of continuing to capture those death data, which are what the model is using for the fits, over a period from April 22nd into the beginning of July. And we can see that the cases were pretty well captured too, except we started to see this big resurgence in mid-June to early July that the model just didn't predict at all. So the deaths plateaued, but the cases rebounded, and the model really missed that rebound of cases. We can repeat this procedure, fitting the model using different subsets of the data. You can see if we fit only using the data up to April 1st, we're really not capturing the deaths or the cases very well. By mid-April, we were doing a pretty good job capturing deaths and cases, and that continued through about the beginning of June. But at that point, we started to really miss the trajectory of the cases. So the predictions were pretty accurate for this period while we were under the shelter-in-place order from about mid-April to June, but this summer resurgence was not predicted by the model. And what happened here is that the whole conditions just changed. The relationship between cases and deaths changed. So suddenly we were seeing a lot of cases, but not a concurrent increase in deaths, potentially because hospitals and doctors got better at treating patients and fewer people were dying of the disease. We saw the public health orders beginning to be relaxed, and we saw that case and mobility data became more widely available. So we no longer needed to rely on just death data. And in fact, we could tell that we were missing a key part of the epidemic by just relying on the death data. And so we wanted to go back to using the case and mobility data. During this period, our governor, Gavin Newsom, made this amazing quote that I just think is hilarious. Localism is determinative. At the time when Cuomo was going on TV every day trying to be as approachable as possible, Gavin Newsom is saying things like localism is determinative. But I think what he meant here is, although our initial public health orders were statewide and they were really imposed as a blanket sort of way of suppressing the epidemic, our way out of the stay-at-home orders was going to be very locally determined by what is the situation in a given county or a given region. Now, the other thing that we can do with this kind of model that I think is actually really useful is we can communicate to the public that this early action saved a lot of lives. So we can do these counterfactual analyses where we take our model and we say, what if instead of imposing the stay-at-home order on March 17th, we had delayed by 1 week? Or what if we had lifted the order on May 1st? Or what if we had never done an intervention in the first place? So what we observed by June 8th was 141 COVID-19 deaths. If we had delayed by just 1 more week, we would have predicted 253 additional deaths. If we had ended the order on May 1st, we would have predicted 422 additional deaths. And without any intervention, we would have seen almost 9,400 deaths just over this period of about 3 months. So that really highlights to us the value of this early action. And I think it's an important message that we need to communicate to the public, that these early actions that these governments took at great cost to a lot of people really did save a lot of lives early in the epidemic. So by the beginning of June, we started to have some new goals for our modeling work. We wanted to now estimate our time-varying transmission parameter, not just from COVID-19 deaths, but also from cases and mobility data. And we wanted to extend beyond Santa Clara County to look at many locations. We wanted to model the impact of superspreading, and we wanted to predict epidemic dynamics going forward, as well as explain differences in epidemic dynamics among different locations. So how does averting,
sorry. Would you mind answering a little question here before moving on to the update?
Sure, yeah, that'd be great.
Yeah, so there is a question. I'll let Michael maybe ask the question. Michael, you put a question in the chat. Are you available?
Yeah, can you hear me? I'm listening on headphones. Yes. Okay, my question was just about, you talked about how the case fatality rate sort of dropped in the later weeks. Did you look at all whether that was driven by changes in the age distribution of cases?
I think it's very likely that that's what was happening. We didn't have specific data on that, but I think it's a combination of a change in age distribution of cases, a change in the efficacy of treatment so that fewer people that were at risk were dying, mm-hmm. and also just that lag that, you know, at the time that we're seeing an uptick in cases, we're not yet seeing the uptick in deaths. Although it turned out that we never really did see the huge uptick in deaths that we had seen previously. I think another important wrinkle on this is that a lot of the deaths in Santa Clara County happened in long-term care facilities. And I think there was a lot of effort to try to get those situations under control. So even while cases were bouncing back, the number of deaths was more under control over the summer because they were working on social distancing and non-pharmaceutical interventions in long-term care facilities.
Thanks so much.
Yeah, thank you. Should I go on?
Yes, please.
Okay, great. So the next thing we were really interested in was averting superspreading. And just to explain a little bit what superspreading is, again, this is probably a familiar concept by now, but it's the idea that there's heterogeneity or variation in the number of secondary infections that each individual infection generates. So when I talked about R naught and R effective, those are both averages. But what we know from epidemics like COVID and like SARS, the original SARS in 2003, is that these diseases are really prone to super spreading, where one individual can infect many, many other people. So they're a huge outlier from the mean. This is an example from the literature on COVID showing some super spreading events where someone went to a bar, a wedding, a temple, and you can see that one infected person was responsible for a huge chain of transmission, whereas in general, on average, most people are not responsible for those huge chains of transmission. They're just infecting maybe one or two other people. So this idea of super spreading or heterogeneity in infection rates has led to the so-called 80-20 rule, which is not really a rule, but more of a rule of thumb in epidemiology, that about 80% of all cases are caused by 20% of infected people. And in fact, real life epidemics can be even more heterogeneous than that. So to look at this a different way, for SARS-CoV-1 in 2003, we saw this extremely skewed distribution of the number of secondary cases. The data are shown here in these bars, and these are data on how many people each infected person infected themselves. You see that the vast majority of people infected no one else. And after that, most people infected one or two or maybe three people, but there was this really long tail where a few people infected dozens of other people. And this was famously in this paper by Jamie Lloyd-Smith talking about super spreading and the role of super spreading in epidemics. So the question we had here is, could you sort of use this heterogeneity to your advantage as a control tool by chopping the tail? So let's say you had a way of preventing super spreading. How close could that get you to epidemic control? Not by doing anything about these situations where you infect one or two other people, but by eliminating these opportunities for super spreading. So we're thinking here about things like banning large gatherings or, cutting down on nosocomial transmission in hospitals. So how far can we get towards epidemic control by chopping the tail? Now, the early evidence had already suggested that COVID was much like SARS-CoV-1 in terms of how skewed its distribution of individual secondary cases were. So we basically borrowed the shape of this distribution from SARS-CoV-1, and we refit our models, assuming that same level of heterogeneity among individuals. And now we're estimating our transmission rates for COVID-19 cases, deaths, and mobility, assuming this heterogeneity. So these are now 5 focal locations: Atlanta, Seattle, Miami, Santa Clara County, and Los Angeles, showing the cases on top and the daily deaths on bottom. So these models are now fit to both of these data streams. And you can see here the data points in black, as well as the stochastic simulations shown in the different colors. So you can see that the model is able to capture kind of a wide range of different looking epidemic dynamics here. And the interesting output here is the R effective over time for each of these locations. So we can see that R naught really prior to any control, R naught started between about 2 and 4 in most of these locations, and it dropped really steeply in mid-March in all these locations. It went below 1 for a period of time, and then it gradually began to climb above 1. So if we zoom in that April to June period, we can see that for Santa Clara County and Seattle, R effective was below 1 throughout basically until the beginning of June, whereas places like LA, Miami, and Atlanta never really got R effective very much below 1, and it was already back above 1 by April 15th or so. So given this fitted model, what is the impact of this chopping the tail intervention? How much can avoiding super spreading actually contribute to epidemic control? So this is our fitted model for LA and Seattle, just showing the cases here and our credible interval of stochastic simulations around that. And we're asking again, what would happen June 1st if we lift these interventions or if we carry out different types of interventions? So again, we're repeating this result that if you lift all interventions, you immediately get this huge resurgence of infection in both LA and Seattle contexts. If you keep the shelter in place, you get a flattening of the curve. But in this case, because our effective was above 1, even under shelter in place, we're still getting some gradual epidemic growth in both LA and Seattle. If instead you really aggressively test and isolate, so you're now isolating 90% of all symptomatic people before they're able to transmit, that was a more effective intervention, and it starts to get the epidemic curve declining. But if we are able to avert super spreading, just the top 0.5% of that distribution of secondary cases with 75% efficacy, we actually found that that was the strongest intervention that we found. So chopping the tail was a really effective intervention, even if we weren't perfectly able to chop the tail, and even if we were only chopping a small part of that tail. So this was a really promising result because it suggested that interventions such as preventing large gatherings could stay in place where other types of interventions might be able to be relaxed, and we could still achieve some control over the epidemic. So we wanted to look a little bit more closely at how this actually works. Here I'm showing the distribution of secondary cases caused over a 4-hour time period per individual infection. So as you might expect, on average, every 4 hours, most people cause 0 additional infections. A few people cause a few infections. And these are those super spreading events here, where over a 4-hour period, people are causing 20 or 30 or 40 additional infections. So the idea is if we take our base distribution here, shown with the blue and the red, and we chop the tail, so we remove this red part of the distribution, what impact does that have on transmission? So if we go from this individual level 4-hour time step to a population level with 1,000 infected individuals over the course of their whole infection, what we find is that chopping the tail has this huge impact on the distribution. So even though we're only chopping the upper 0.1% of this tail, we're going from an average of 2.5 secondary cases to an average of 1.5 secondary cases over the course of the entire infection for these 1,000 people. So we can see that there's a huge impact of chopping the tail on the mean of this distribution. So we then wanted to compare this impact to the impact of shelter in place in our population. So what I'm showing here is the percentile of super spreading averted on the x-axis versus the proportion of the population sheltering in place on the y-axis. And these bands represent the combination of interventions that brings R effective to 1 in each of these different locations. So what you see here is that there's this sort of trade-off, or there's this combination where if you're chopping the tail, you don't need as much of the population to be sheltering in place. And just to give a frame of reference here, the maximum level of shelter in place that we ever saw in these locations is here. And the minimum level, sort of the baseline mobility, is here. So essentially, by chopping a little bit of that tail, we're able to go from essentially total shelter in place to much, much less, and even baseline mobility, assuming that we're able to go to baseline mobility while still chopping that tail. So the next question we had, which was perhaps somewhat optimistic, but in June we were thinking, okay, maybe these interventions will get the epidemic under control and we'll want to be able to lift these interventions, but we don't want to have a resurgence of disease. So what happens if you have an epidemic that's declining towards 0, but it's not quite at 0 yet, and we lift all interventions versus keeping the chopping the tail interventions in place, but lifting everything else? So can averting super spreading give us sort of an insurance policy against resurgent epidemics? So what we do here in these simulations is we're lifting all interventions, but we're either just lifting all interventions, shown in yellow, or we're chopping the tail with either 60% or 100% efficacy, shown in the green and blue colors. So you can see from looking at these simulations that if we just lift all interventions when the case numbers get low, we're pretty likely to see a resurgent epidemic. And that epidemic can get very large very quickly. Already we can see that chopping the tail helps to protect against those large resurgent epidemics. So then we looked at the probability of a resurgence versus the epidemic dying out. So here on the y-axis, I'm showing the proportion of epidemic simulations that went extinct. What we found is that this proportion of simulations that went extinct was really sensitive to how many infections were still left when the interventions were lifted. So if there was only 1 left, these simulations were pretty likely to go extinct. But once you had 5 infections left, they were much less likely to go extinct. But then we looked at the efficacy of truncation. So this is our chopping the tail. And you can see that chopping the tail is helping a few more of these simulations to go extinct in cases when they wouldn't otherwise. The next thing we looked at was, given that the simulations didn't go extinct, how large was the resurgent outbreak? So here's the 99th percentile of concurrent infected. So that's sort of this upper credible interval here versus the amount of chopping the tail that we're doing. And what we see here is that when we don't chop the tail, these resurgent epidemics can get really big really quickly. But when we do chop the tail, we're really constraining the size of those resurgent epidemics. So the key conclusion here is that, averting superspreading caps the size of resurgent outbreaks and makes them slightly less likely. But the main effect here was on capping the size of the resurgent outbreaks. Now, one additional subtlety here that's kind of interesting is that, as I showed you earlier, chopping the tail not only changes the shape of the distribution, but it predominantly reduces the average. By chopping the tail over this 4-hour time period like we did, the average number of secondary infections goes way down. So we were interested here in how much of this effect is driven by changing the average versus changing the shape of the distribution. So to ask that question, we basically compensated for this change in average by chopping the tail, but then compensating by allowing the shelter in place to be relaxed so that our average number of secondary cases would stay the same, but our shape of the distribution was changing. And so when we did the same process using that second, so now we're compensating by keeping the mean number of secondary cases the same, by relaxing the shelter in place, we see that this type of truncation intervention now has a much lesser effect than it did when we allowed the mean to change. We see that now any benefit in terms of driving simulations extinct really kind of disappears. And we see that there is some minor benefit that we still get in terms of capping the size of those resurgent epidemics, but it's much smaller than when we allowed the mean to change. So most of this benefit that we're getting from chopping the tail comes from changing the average number of secondary cases rather than changing the heterogeneity per se. So the next thing we wanted to ask is, how predictable are epidemic dynamics over time? We now had this modeling tool that was flexible enough that we could fit to these publicly available data streams across anywhere in the country. So we took this model and we started fitting it to these 200 different counties, selected to represent a wide range of different demographic conditions across all the states. You can see a few just example trajectories of different types of epidemics in different locations here. So you can see that the epidemics looked pretty different in different locations. These locations also differed quite a bit in their demography. So population size, population density, the duration of the stay-at-home order, and the median household income. So this was just a test to see whether this model structure was going to be able to accommodate this wide range of different epidemic conditions. And just to show you a few examples of what these epidemics look like in different counties, you can see cases on the top and deaths on the bottom, and the fitted model stochastic simulations are shown in the different colored lines. So you can see that the model is capturing a wide range of these different types of epidemics. And if we look at our effective over time across these different counties, we can see that there are some differences and some similarities in their shapes. Most places had a pretty high R effective, followed by a steep drop in the spring, followed by sort of a gradual summer resurgence that then kind of tailed off and dropped again. So now that we have these 200 fitted models, we wanted to ask something about this population of epidemics across the country. The first thing was, how have these interventions affected transmission rates? And the second thing is, how predictable are these epidemic dynamics? So we can divide our epidemic in each county into these kind of 4 epidemic phases. The first phase is this uncontrolled early epidemic phase in blue. The next phase is this early control period in orange. The next phase is this green period, which was the summer resurgence that most places had. And then the final phase is this black period, which is 1 month out of sample, where the model was not actually fit to those data. And we wanted to ask how R effective changed during those periods. So if we look at the early epidemic phase, sort of by definition here, we had a fairly high R effective in most places, centered around 2, but with a pretty fat tail. Some places had really high R effective early in the epidemic. By definition, once we got into the control phase, the R effective is less than 1. We had R effective less than 1. On average, it was at about 0.8 across these locations. In some cases, we had some lower R effective, but typically it was actually pretty close to 1 still. And then during the summer resurgence phase, we saw that R effective did climb back above 1, but it was still well below that early epidemic phase. It was centered around about 1.25 at that time. So how well were these fitted models able to actually predict epidemic dynamics? These points show the predicted versus observed. In this case, it's cases during the early epidemic phase across these 200 different locations. And you can see that the model had pretty high predictability. So predicted versus observed, R squared was about 0.78 in the early epidemic phase. And in fact, if we look across all 4 of these phases, including the out of sample phase where the data were not used to fit the model, we have fairly high R squared, especially for cases. So above 0.75 for cases. For deaths, it tended to be closer to about 0.5. So the deaths were slightly less predictable than the cases, but still we had fairly high predictability across this wide range of different types of counties and epidemics. So the key result here is that epidemics were highly predictable during the early first wave control, resurgence, and 1 month ahead periods, suggesting that although this epidemic is unprecedented in terms of its scale and scope in our lifetimes, it's actually fairly predictable using these pretty simple types of models and pretty flawed data streams, really. Now, the next step on this work that I unfortunately don't have really great results to show is we really wanted to ask why these locations differed in their epidemic dynamics. And one observation that we've made right off the bat is that our effective changes, again, this is just a sampling of these 200 counties, these R effective changes actually preceded the stay-at-home orders. So in the vertical dashed lines, you see the date in which the stay-at-home order went into effect. And in almost every case, these places are already seeing steep drops in R effective before the stay-at-home orders were enacted. So that suggests that there's something going on beyond just people sort of responding to policy directly. And that kind of gets us into this last segment of the talk, which was what was the impact of early policy decisions? I think as was mentioned earlier, I'm from Georgia. I grew up there. I went to UGA. The student in my lab who worked on this, Mallory Harris, is also from Georgia and also went to UGA. And so we got really interested in the case of Georgia for several reasons. Looking at this map of the date of first cases, we see that there were quite a range of dates of first cases across counties in Georgia, ranging from early March to all the way into late April. And Georgia, as you probably know, being residents of Georgia, has 159 really tiny counties that are really a huge range of different demographic conditions and epidemic and political conditions. So Georgia is really a case study in localism is determinative, to quote Gavin Newsom. And part of the reason it was such a case study is because, as you know, the governor of Georgia delayed for a very long time declaring the statewide shelter-in-place order. So whereas the California order went in place on March 17th, it was about 3 weeks later, almost 3 weeks later, that the Georgia stay-at-home order went in place. And what happened during that intervening period is that a lot of these counties declared their own social distancing and stay-at-home orders, as you can see in these pink colors here. So we thought this might be a great opportunity, sort of a natural experiment for looking at how these local orders had an impact on epidemic dynamics. So just to zoom in on a few different dimensions of the state of Georgia here, we have our date of first case that I just showed you and our local social distancing orders. There's, of course, a huge range of racial composition in the counties of Georgia, which predominantly white counties shown in green and predominantly Black counties shown in red, and a mix sort of in between there. There was also a huge range in mobility. This is measured at the end of April. There's, of course, a large range in population with Metro Atlanta shown here in the middle. And finally, looking at the map of COVID-19 deaths, we can see quite a bit of range across the Georgia counties as well. So using this variation, we wanted to ask what was the impact of these early policy orders on COVID-19 epidemic outcomes? So the model we're thinking of here is how does policy affect COVID-19? But of course, we know that policy doesn't directly affect COVID-19. Theoretically, policy is going to affect behavior, which affects COVID-19 transmission. But as we started thinking about it, we recognized that policy wasn't going to be the only thing affecting behavior. We would also see effects of things like health and socioeconomic covariates. So people may be less likely to move around if they know they're at high risk of severe COVID, or they might be more likely to move around if they're not able to work from home, or they live in a remote location, or you know, in terms of their lifestyle doesn't permit basically staying at home. So we thought there could be an important effect of these health and socioeconomic covariates. But we also thought that those health and socioeconomic covariates could themselves affect COVID-19. And finally, we thought that they could affect the probability of a policy being enacted. So we know that there was a lot of partisanship, for example, in these policy decisions. We also thought that the places that had early large COVID outbreaks might be more likely to enact policy. So as we're trying to think about the impacts of policy on early COVID outcomes, we realize that there's this sort of dynamic feedback going on between these factors that might control both COVID and policy decisions. So to address this, we're not able to really make a simple, causal regression that tells us directly what's the effect of policy on COVID. Instead, we sort of broke this process up into a series of different mechanisms. So first, we looked at what predicts which counties had those local policy orders. And then how did those policy orders affect behavior? And then what are the other factors that affected behavior? And then how did behavior and those other factors combine to affect COVID-19? So we're going to walk through these regressions one by one. So first, looking at the predictors of local policy orders. These are the local social distancing orders. As you might expect, the places that had local social distancing orders had much larger populations and had much larger shares of Democratic versus Republican voters. So this is a share of Republican versus Democrat voter turnout. If we look at, so social distancing orders, I should say, are anything from limiting gathering sizes to limiting capacities in stores, ordering face masks, closing schools, anything like that. Stay-at-home orders are a more severe version of that, where they really order people to stay at home. And the probability of enacting a stay-at-home order was again related to population size, but it was also related to the date of first case. So here's where the local stay-at-home orders were really probably in some ways responding to the local epidemic situation. The next thing we looked at is, did these policy orders reduce mobility? This is cell phone-based mobility data. And what we're doing here is called an event study, where you basically align all these counties as if they all had their event, their social distancing order enacted on day 0. And you say, what was the change? You use the statistical model to ask, what was the change in mobility from before the order to after the order? And what we see here is that after the order, mobility began to decline fairly gradually, but over the course of 10 days, we saw a 19% decline in mobility following a social distancing order. Now, in all of these counties, they had a social distancing order before they had a stay-at-home order. And we found that once these social distancing orders were in place, the shelter-in-place orders on top of the existing social distancing orders had very little impact on mobility. So it was really that kind of early social distancing order that appeared to have the biggest impact on mobility. So then we looked at what other factors affected mobility. And here we saw that mobility was lower in populations that had an older age distribution, a higher level of income, and a higher share of Black population. So this may reflect some combination of people's perceived risk of severe disease, their political affiliations, and their income, their ability to stay at home based on what types of jobs they're working or not working if they're retirees. So finally, we did this fourth regression looking at the predictors of COVID-19 epidemic dynamics. So here our response variable is COVID-19 cases by population size. And as you would expect, we saw larger numbers of COVID-19 case rates in higher population counties, in populations that had a larger share of Black residents, and in populations that were older. We did see that mobility was a significant predictor of cases, but only in the counties that weren't involved in the super spreading events that happened early in Georgia. So it wasn't a totally robust predictor, but there was a signal that mobility had an effect. If we look at COVID-19 deaths as our outcome, we see that again, population size, the date of first case, and the level of education were the strongest predictors of COVID-19 deaths. So what this suggests is that although policy orders are designed to act on behavior, and although behavior may have had some effect on COVID-19 epidemic outcomes, we see a lot of other effects that are driven by sort of structural factors that weren't necessarily under the local government's control to try to affect. So to summarize the results from these kind of 4 components, we saw that the counties that were most likely to enact local policy orders had larger population sizes, larger shares of Democratic voters, and earlier first cases. Those social distancing orders did reduce mobility by about 19%. Factors like age, income, and race also affected mobility. But despite the reduced mobility in these older and higher income and larger share of Black populations, we still saw that population size, age, race, education, and the date of first case were the key predictors of the epidemic outcomes. So it sort of suggests that there are potentially limits on how much these policy orders can actually affect epidemic outcomes, given the realities on the ground. So to summarize this part, behavior changes dramatically reduced mobility and are effective, and socioeconomic and demographic factors mediated these behavior changes. These combine to affect COVID-19 epidemic outcomes, and the early COVID-19 epidemics themselves affected policy. So policy is not this independent thing acting on COVID. Policy is also responding to COVID, which really makes this a complex situation to try to understand. So before I close, I just wanted to kind of revisit our situation at home in Santa Clara County. As we've seen in many other parts of the country, we've seen multiple waves of disease. This is our case count, and this is our kind of puny little thing that we were responding to back in March. We had a pretty large summer resurgence, and then this huge sort of November into December holiday period resurgence that we've seen in many other places that's starting to recede now, finally. Santa Clara County is in many ways a microcosm of the country itself, in that we see a huge amount of heterogeneity in infection rates. If you look at the geography of Santa Clara County, this is Palo Alto and Mountain View. These are like the really, really wealthy areas where houses are millions of dollars. And this map of COVID infection rates essentially matches the map of housing costs in the county. So if you go into these more outlying areas of San Jose, Morgan Hill, Gilroy, housing costs are lower, incomes are lower, and COVID rates are about 4 times higher than they are in places like Palo Alto, where most people are able to work from home. Reflecting that heterogeneity on a racial lens, we see that, as in many other places, Latinos are very overrepresented in the COVID-19 cases. So in blue is their share of cases, and in orange is their share of the total population. You can see that there's a large overrepresentation of Latinos in cases, but in COVID-19 deaths, there's actually not much overrepresentation. So that really kind of disappears for deaths. The picture of vaccination in our county is becoming somewhat optimistic. About 12% of the population has received their first dose. But unfortunately, that racial disparity that we're seeing in cases in our county is not being overcome, at least so far, with vaccinations. You can see that the Latino and Hispanic group is very underrepresented in the population that's been vaccinated so far, compared to, for example, the white and Asian groups. One effort that our county has been making to try to overcome some of these disparities that I think is somewhat encouraging is they've provided assistance to people who are forced to isolate or quarantine because of COVID. So in these teal bars are this hotel shelter, in-home support, and rental and financial assistance that people are receiving. And you can see that this has sort of gone up in proportion with the numbers of cases, but there are more and more people in the county who are receiving some of this assistance to try to help with isolation and quarantine. But it doesn't seem to be overcoming the problem of inequality, at least yet. So just to review the 4 key points that I made today. In the first part, we showed that early models are useful for decision-making, but only for a fairly short time during that kind of initial epidemic situation before conditions start to change. In the second part, we showed that averting superspreading is a really powerful tool for controlling epidemic dynamics, and it primarily acts by changing the average number of secondary cases. In the third part, we showed that epidemic dynamics are highly predictable, even though they're fairly variable and stochastic across a lot of different locations. These fairly simple models can really capture epidemic dynamics pretty well. And finally, we showed that socioeconomic, policy, behavior, and epidemic dynamics are tightly interlinked with each other. So it's really hard to separate out causal relationships between specific socioeconomic or policy or behavior factors and epidemics. So with that, thank you very much. The work that I've showed today is available in some preprints and papers, and I'm happy to take any questions.
Thank you so much, Erin.